keep up with my schedule. It's driving me crazy. If I could just work with you all, I would be a very happy person. Hold on just a minute. Let me start. All right. And give you a few announcements here in just a second. Let me. All right, technology is working. Okay, so we will not have an exam next Wednesday because I do have to be at FDIC. I'm speaking on that Wednesday. We will have, unless you hear differently from me, we will have class, but it will be broadcast from Indianapolis and recorded and all this stuff. So again, I know you're going to be at FDIC. I know several other people are going to be there. That's okay. Just watch the video. So I'm working. I spent work this weekend working on your study guide for your next exam. I'm just about finished with grading your exams. Got one student left that needs to take their exam, and that'll be done this week. So hopefully everything will be ready to go and back to you by Wednesday. You have an assignment for this week. It's one of the few assignments that I've uploaded. Oh, it's okay. So please make sure you don't blow off. You are in a mood today, man. I'm telling you. Okay. You and I'll get along just fine then. Please don't blow off the assignment because I'm wanting to kind of do some things to help you learning and stuff. So make sure that it gets done. Any questions, anything we need to discuss? Obviously, FDIC, if you're going to it, you'll be excused from all the classes because, well, Holly will be there all week. I'll be up there Wednesday for my presentation. So anything we need to chat with? Yes.
What presentation are you giving?
It is on, this is why I liked so much when McKenna made a remark last semester about, I wonder if Dr. Young knows about TikTok store. No, because it's such low hanging fruit that I love it. I'm lecturing on the use of artificial intelligence in the EMS classroom. I think I know about TikTok store a little bit. Look. I would ignore you if I didn't like you. Okay. So again, you're in the same class as everybody else. I really like you, so I pick on you. All right. And you're free to pick back on me as well. What?
Now, Jack, did you real dirty? Jack, did you real dirty?
I'm old. I didn't hear Jack. You, I heard perfectly well. So listen.
I'm an angel.
Demons are angel as well.
True.
All right, let's get into the second part. Pardon. Haley brought the donuts.
Oh.
So, again, we're going to finish up with toxicology this week. The content for this week and next week will be on your exam. So, most likely what I'll do is we'll do a review. Well, maybe next week won't be. Maybe Monday. Well, Monday, everybody will be gone for FDIC on Monday, won't they? Because it doesn't start, or does it starts on Monday? Disregard what I just said. I'm having a Monday moment. Anyway, let's talk about toxicology this week. All right. So when we're talking about toxicology, we do have to have a discussion about activated charcoal. Now, keep in mind, let me ask you a question. On your trucks, those that are working on a truck now, how many people are carrying activated charcoal? Yeah, that's what I thought. I'm giving you this lecture on activated charcoal so that should you have a question on your registry exam, you will be familiar with what it is when the quote indications are. But we don't use activated charcoal anymore for a number of reasons, and very, very good reasons. Basically, in the past, what we used to use was activated charcoal that had sorbitol in it. Sorbitol is something that if you chew sugarless gum or you eat any kind of sugarless candy, that's what sweetens the candy. It's an alcohol-based artificial sweetener. The thing about sorbitol is in high quantities, it also causes diarrhea. So if you chew a bunch of gum or eat a bunch of sugar-free candy, you're probably going to spend a lot of time in the bathroom. The primary reason that sorbitol is in activated charcoal is to lead into the absorption, and actually it's not absorption, it's ADSORB. That might be a question that you would see. Activated charcoal works by the large surface area of this slurry that we used to give to patients, and it would adsorb or adhere to the surface of the individual parts of the charcoal. Now, basically what happened in this is that it would link onto the surface of the charcoal, and then it would keep it from being absorbed into the system, and then ultimately would be evacuated when the patient had to go to the bathroom for diarrhea. It is, let's be honest here, it's contraindicated in almost all situations now, again, primarily because it's a really, really thick slurry of just, bless you, nasty stuff, and it would get all over your uniform. If the patient was combative or if they started vomiting, it would get all over the back of your truck, and whatever it touched, it stained. So when you got it on your uniform, don't even bother to take your uniform home and wash it. Just take your uniform home and burn it, because that wasn't coming out. The physiological or pathophysiological reasons why we don't give it anymore is that, remember, when patients overdose, we're always going to be concerned about vomiting and altered mental status. The last thing we want to do is to have a bunch of activated charcoal into the alveoli, because those alveoli are going to be gone forever. You're not going to get them back. So it takes black lung to an entirely new level. So as we're looking at this, the thing that we're looking at is the patients would often not drink it. They just, because it tastes nasty, it looked nasty, it colored their mouth black, it colored their teeth black, and so they would refuse to take it. And so rather than fighting with the patient, rather than dealing with a patient that would have to be an airway issue, we just simply began to take it out. Now, occasionally, if you wind up working in a hospital, and I know some of y'all are going to, you may still see it within the hospital. If you are, you need to protect yourself with full hazmat gear of gown, gloves, mask, and eye protection, because again, sometimes if it goes somewhere, it's going to go everywhere, and it will make a huge mess for your patient. It is contraindicated for almost all patients now, but specifically it would be contraindicated for any type of caustic or lye acids or alkalis within the body, because basically it would hold them there and keep the burning sensation going much longer. Bottom line, what I want you to remember about activated charcoal is, number one, it's got heavy amounts of sorbitol in it. Number two, it adsorbs, ADSORB, instead of absorb. Absorb would mean that it would take it within the various molecules of the charcoal. Now what it does is it links onto the surface. And in order for it to work, you have to have lots and lots of it in the GI tract. Any questions on charcoal? You will almost never give it. I can't, again, I've been here for almost 15 years now back in Kentucky, and it was coming off of the trucks 15 years ago. Just simply, it's too much of a risk for our patients. Similar thing with it, and you'll notice I don't even do a lecture on syrup of Epicac. Okay, that works well if you got kids that take things, poison control will still recommend syrup of Evicac, but we don't give that anymore either. Caustics. Caustics are acids or alkalis that have a big issue of being able to burn or corrode. And typically what we're looking at are these things that are found most commonly within like toilet bowl cleaners, rust removers, certain types of paint, ammonia, and most all liquid drain openers. Those are some really serious types of problems. Generally, what we will see with kids is that they will, and in particular, we'll see this with toddlers in the fact that they will begin moving around and they'll get into the bathroom. They're at that same level of in the bathroom or in the kitchen. They pull out things. These things are brightly colored. It's interesting to the child. They open it up and they take a drink. Now, here's one of the good things about it. As soon as these kids take a drink, they're not going to take a second one. So that's one good thing. The downside of that is that they're going to spill it on themselves. And so again, because of these chemicals and the way that they function and they react, not only do we now worry about internal burns, primarily of the mouth, because it's generally not, once it gets into the mucous membrane, it's going to start reacting really quickly. So rarely do these kids swallow much, if any. But generally what happens is that when they tip it up, they don't have good fine motor control anyway, and they spill it on themselves. So not only are you dealing with an internal burn, but you're also going to be dealing with an external burn. When we're talking about acids and alkalis, some of the things that we need to be concerned about is number one, how concentrated it is, what type of body tissues that it came into contact with. Obviously, we have better protection with our skin against these substances than we would the mucous membranes or even the esophagus or the alveoli, as well as how long the contact was. And so this is important things to try to figure out for these kids. Now, again, it's not only related to kids. There have been documented cases. I had at least one person who attempted to commit suicide by drinking Drano. Drano is lye. It is very caustic. It's a very strong alkali. So this person was intent on doing himself harm. And basically he drank it, and basically what results now is perforation of the esophagus. Now, when we're talking about perforation of the esophagus, what kind of problems arise from that? This is your part.
You have an airway issue.
You have an airway issue as a result primarily of what? Two things. Bleeding, because remember we've got the esophageal artery and the vein that run right down through there. What else? Inflammation of the esophagus gets very inflamed, but again, that stuff gets into the stomach. And what does the stomach do when it doesn't like what's in the stomach? It all comes back up. That leads into a double problem. Now, again, it's coming back up. Anytime we have vomiting, we're going to be concerned about an airway issue. But remember, it burns on the way down. And guess what does it do on the way back up? It burns again. And the tissue has already been damaged. And so it makes that burn twice as bad. This can potentially lead also into internal organ injury in the fact that if it dissolves enough of the GI tract, primarily the esophagus and the stomach, now some of that material, along with the acid from the stomach, and the stomach makes really very potent, very strong acid to be utilized in the digestive process. Now that leads into a big issue with damage to the internal organs, not only from peritonitis, but also from the actual chemical itself. Generally, what we're looking at with this is that acids typically cause necrosis in what's known as coagulation necrosis. Basically what happens is it turns whatever occurs, whatever it touches, into a type of a liquid goo. It no longer has the structural capacity of skin. But basically what happens is that it dissolves the skin. Now, the other thing to keep in mind is acids typically do not cause as severe a burn as do alkalis. Does anybody remember why? Why though? You're right. Acids cause pain instantly. Alkalis typically do not cause instant pain, which you're exactly right. Why it leads into, and it does what to the nerve endings? It sears the nerve endings really, really quickly. Now, remember what I said a while ago is that when we're talking about a toxic exposure, we're talking about concentration, the area of the body that has been exposed, as well as the time that the patient has an exposure. You get an acid on you, you're going to know right away, okay? Because does not basically, as Wyatt says, it doesn't sear the nerve endings. In order to have pain, we have to have an intact nervous system. If we go in and we just like putting a steak on a barbecue or in a cast iron skillet, and we sear that, we close that off. And so patients who are exposed to alkalis will often have the same chemical or that chemical on them for minutes to hours. Basically, what we're looking at here with any type of an acid or alkali involvement is, number one, you're dealing with a hazmat incident. Understand that unless you are with a fire department and you have specific training in hazmat, your fire department is going to be your best friend. They are the experts in hazmat. They are the experts in decon. So involve them, especially if you have a large scale incident. But a couple of things you got to do is you got to get your patient, you got to get the clothing off of them, again, regardless of whether it's an external exposure or a combination of internal, external, as we would see within like a child, resulting in now basically not wanting to get that stuff on you and then move it into the ambulance and then move it into the hospital. Decon your patient before you move them into the ambulance. And for decon, if you're dealing with just like a small child, just plain water, room temperature water. We don't want them to shiver, but we also don't want it to be so hot that it's going to burn them as well. It can lead into huge problems. If we're dealing with exposure to the eyes, we want to begin and we want to drain, we want to flush that eye for a minimum of 20 minutes. Now, it's been really interesting because I've watched this whole thing of minimum of 20 minutes of flushing an eye. Back in the dark ages, if you go and look at that orange textbook that I've got on my bookcase in there, that's a copy, not my original copy, but I found one of the same EMT book that I used back in 1975. And in there, it says, we're going to flush for a minimum of 20 minutes. Trust me, it's going to be much longer than 20 minutes. Several ways that you can do this is, again, make sure that if a patient is wearing contact lenses, those contact lenses have to come out. If they're soft contact lenses and you get an acid or an alkali in there, they're probably already going to be fused. So they may or may not come out. If they're hard contact lenses, and I don't even know, do they still make hard contact lenses? Do they? Okay. Lee's shaking her head. Yeah. Yes. No. If you're deconning the exterior. So we'll talk just a little bit about what you might be able to utilize internally to, I hate to use the word neutralize because that's not the best word, to buffer what would be for these particular patients. But as far as for an external, we're just going to use plain water on that. Okay. Yeah. No. I'd say something that doesn't make sense. Point it out. Couple ways of irrigating the eyes. Number one, you can use a Morgan lens. Okay. Now that's going to be really uncomfortable for your patient. or you can simply spike a bag of normal saline with, and connect your IV tubing into a nasal cannula. And what you want to do is you want it to drain into both eyes. If you have exposure on one eye only, put the eye that has the exposure to the bed, because the last thing we don't want to do is to have the fluid draining from this eye that's been exposed into this one that has not. If it's both eyes, don't worry about it. Just set them up and let that go in, and set it at a slow rate, and just simply begin to drain and to cool the eyes. When we're looking at this, basically coming back to what you were saying just a second about dilution or buffering, is that the ideal thing to give a patient if they ingest a caustic substance is some milk. Okay. And basically about 200 to 300 milliliters of milk. But you got to watch your patient really closely, because again, if we're dealing with a child is going to be afraid. They're going to be afraid that they're in trouble. They're going to be hurting. Mouth is going to be burning. And the last thing we don't want to do is to upset the child to the point of where now they begin to vomit. And so again, that's a potential treatment that you might want to use for your patients, but it's not definitely going to be something that has to be done. This is where you come in and you assess your patient and you think, okay, let's give the child a little bit of milk. Let's see how they do. And then we can go on from that. Whatever you do, regardless of the route of exposure, you never, 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 never try to neutralize an acid with an alkali or vice versa. Here's the reason being. Number one, if you're going to neutralize an acid with an alkali, it's got to be the same strength, okay? And rarely are you going to know what that strength is going to be. Here's the other thing that's even more important. One of the few things I remember from chemistry, when you neutralize an acid with an alkali or vice versa, you release a large amount of heat and you're making a bad situation worse. So again, that's the last thing that we don't want to do, is we don't want to turn this in from a chemical burn, especially if we're talking about eyes or internal, into a thermal burn. Okay. So again, buffering is actually a better way of putting that as far as that goes. Questions about acids or alkalis? Okay. Takeaway message here is, again, know the difference between the two, of which one will burn instantly, which one will take some time. Acids, you'll know right away. Alkalis, it will take a little bit of time for the patient to begin to notice, because the damage has already been done. Buffering internally wise with some milk. The higher the fat content of the milk, the better, because the fat will kind of coat the stomach and help to do this. So if you can give skim milk or fat-free milk, but it's not going to be nearly as effective as if you are giving whole milk for your patient. And lots of water to irrigate eyes or externally, as far as when we're going on here. Hydrocarbons are a group of compounds that are mainly come about from oil or from coal. And generally what we would see is these hydrocarbons vary in their viscosity. Now, viscosity just simply refers to the thickness of what they see. So for example, we all know that if you have a quart of oil over here for your car and you've got a quart of gas over here, the oil is going to be much thicker than the gas is going to be. Now, the thing they're going to remember is viscosity is really important if we have an internal exposure, and especially if we have an internal exposure that involves the respiratory tract. The lower the viscosity, the more volatile a hydrocarbon will be. That means just by exposure to the chemical itself, it can cause an additional increased amount of damage for what you're going to be able to see here. Also, the lower the viscosity, the greater the chance for that hydrocarbon to vaporize. Again, when a hydrocarbon vaporizes, the flammability of that substance goes up dramatically. That's why if you're trying to light something over here that you've got motor oil or kerosene, it takes a higher flash point because it's thicker than if you're dealing with straight gasoline over here on the other side. Now, generally what we're looking at here is much like what we would see with our patients that we talked about with acids and alkali, the same situation comes into play here. Most commonly, where you're going to see patients that are going to be exposed to acids or alkalis, to hydrocarbons, are people who are either legally or illegally trying to siphon gas. They will often get a mouthful of gas, it burns, it causes that sudden, and now they've got a small amount in the respiratory tract that can lead to, again, liquefaction. We see other types of hydrocarbons in like metal cleaners, other household cleaners that we would see within the house. And again, quite frequently, these ingestions, these emergencies that you're going to come into contact with are going to be primarily dealing with children. Now, some of the other more common type of areas we'll see this will be paint thinner. Paint itself is a hydrocarbon basis, as well as turpentine, which is a type of thinner that goes in there. A lot of your patients will be exposed through the use of, particularly for external exposure for lawn products, especially starting up in the spring when they begin to fill up lawnmowers and things along that line of there. Again, when we're looking at these particular patients, the more volatile it is, the thinner the hydrocarbon is, the more damage that it will do. Most of the time, these hydrocarbons are primarily going to be externally exposure for a patient. But again, the fumes of themselves are serious enough that if they're in a confined area and your patient is breathing those in, it can lead into some major issues as far as that process that goes. Generally, what we see with the respiratory system is that if you inhale the fumes in, it results in a rapid inflammatory response. Now, let's think back to your anatomy and physiology. All right. Now, tell me what happens when we get an inflammatory response within the respiratory system. Do a little bit of review here.
Their airways become constricted.
It's going to become constricted. Now, here's a couple things to remember. Number one, it's going to become constricted because the bronchioles are going to react. But on top of that, the bronchioles are also going to swell. So unlike what we would see with a patient that is having an asthma attack, where we primarily see bronchial constriction from the constriction of the bronchioles, we have that in addition to, we have the edema that comes about from the inflammatory process. Now, let's say that you're dealing with, you're dealing with somebody that's been exposed to gasoline in a closed environment. It did not ignite, so we're dealing with the fumes. We're not dealing with thermal, we're dealing with chemical. So we have that inflammatory response within the lungs themselves. What else may you see as far as damage to the lung tissue? Say it again, Zeke. What would be burnt? And the lung tissue that we're most concerned about is what? Alveoli. Excellent, Rebecca. So again, remember, when we get burns within the alveoli, whether it's thermal, whether it's chemical, there's multiple things that begin to happen to them. First of all, we lose the structure. What is the big issue? You're thinking, okay, Bill, you're losing your mind because you're talking about emphysema here, but it ties in here. What is the big issue with diffusion in patients who have emphysema?
They can't get air out, so carbon dioxide builds up now.
Why can't they get air out? You're right. So we get a lot of air trapping, but again, get down to the structure. What happens that causes that air trapping? Destruction of our alveoli. So now rather than having grape-like clusters, it's like we've got great big floppy areas in there. And that's what leads into that air trapping, and we get reduction of that elasticity over a long period of time. A similar, not the same, but a similar thing can happen when we have a chemical destruction or a thermal destruction of the alveoli as well. Remember, in order for the alveoli to work, they got to be intact. So when you destroy off part of the alveoli, the entire alveoli is gone. But wait, there's more. Again, what else is going to happen to the alveoli in that destructive process? Part of the inflammatory response.
Are you gonna get pulmonary edema?
We're going to get pulmonary edema. Excellent. Yeah, we're going to get pulmonary edema. So the alveoli that are still intact are going to have a tendency to begin to fill up with fluid. Now, let's think about this for a second. When you are dealing with a chemical exposure, hydrocarbon exposure, what is your treatment priority going to be for this patient? Walk me through, what would you do for this patient if they're having severe respiratory distress? You're hearing wheezing and you're hearing crackles. Typically, we don't hear crackles in asthma, but now you got wheezing and you got crackles. Okay, now let's think about that for a minute. Is that going, now I'm just challenging you. I'm not trying to lead you down that, well, that's not the right answer. What if you put them on basically CPAP or BiPAP? Is there a possibility that could make their damage worse? And if so, how? It's Monday, Bill. No one said we'd have to think today.
Yeah, if they're gonna, I mean, if their alveoli is already getting all big and floppy, I mean, you're gonna expand it more, and it's gonna make it a little worse, but at the same time, they have to get oxygen somehow, so it's like.
Yep, you're exactly right. Good rationale. So yeah, so the first thing we got to do is that we've got to get that in there. But now here's the problem. CPAP initially is probably not going to work. Why?
Once you put that mask on their face with the pressure, they're just gonna freak out even more.
Especially if you got a person who's claustrophobic. Yep, you're exactly right. But think anatomically. What has happened anatomically that is probably not going to make your CPAP effective, at least at first?
They're both restricted and all swollen.
Yeah, so we've got bronchoconstriction and we've got edema. So what we've got to do then is that we've got to get it in there and we've got to utilize our tools to help to bring about some bronchial dilation. What are you going to use? Going to use a Duodenal, okay? If that doesn't work, what's going to be your next step? Good question about epi. Okay, let's think about it. Epi. Okay, is epi going to have any potential negative consequences that you need to be thinking about for this particular patient?
Vasculature a little bit, might need some more fluid moving in.
I love being around smart people. Yeah, so now we got to keep taking. Now I'm not telling you not to use it, but again, for every drug you give, there's always a potential of a negative side effect. So yes, we could actually make the pulmonary edema worse, okay?
Would mag be better?
There we go. So I would tell you, again, you've got to look at this based on the situation that you're in. But I would tell you to go with your Duneb first, and then I would tell you to go with your mag sulfate. Why mag sulfate? How does mag sulfate work? It's a smooth muscle relaxant. Okay. It potentially might actually help some of the inflammatory process, just as kind of a part of that dilation of the bronchioles. Now, it's not going to have a huge impact on the inflammatory process, but again, that would be something that you would look at. So again, when we're looking at this is going to be things that you're going to do concurrently. Okay. Not, we're not going to go with our drugs first and then we'll go with CPAP or BiPAP. But again, getting your patient on that and then and doing this drug therapy concurrently with it would be extremely important. What are going to be some indications that your patient is getting better? Very good. What would you expect on your patient's mental status? If, let's say, for example, all right, let's use a real world example. Let's say that you've been called Friday night to a party at a vacant warehouse and you got a bunch of teens and they've been huffing paint. And they got all the gold and silver around their face because you have to have more of the accelerant or propellant to get that heavier metallic paint out. And you've got these patients that are going, what would you expect their mental status to be? Altered how? Euphoric and agitated. Okay. So again, in this situation, now you got to be concerned. Now I got a scene safety issue because again, they can move from euphoria to agitation and combativeness really, really quickly. Okay. Yes. All part of the chemical process that goes in. Again, think about the whole reason why people huff paint. They want to get that high. When we begin introducing things into the body that affect, in particular, the GABA receptors, once they get in there, depending upon how the anatomy and the physiology works, literally it could affect one person one way and the second person another way. This is why some people, when they get drunk, they're your best friend. They're happy, they're shiny, they're just kind of fun to be around. Other people, when they get drunk, they get mean. And again, this all depends upon the anatomy and physiology of the brain. And there's no way that you can look at a person and say, oh, I know what this person is going to be as far as their altered mental status. So you have to take it into consideration. Very good question. Yes.
Going back to treatment, CPAP and you're doing that, and that doesn't work good in MAG. If MAG is not effective, would this patient be a good candidate for like RSI?
Ooh, all right. What do you think? Why?
Trending downward and their airways constricting and everything you give does not work, just take their airway.
Remember, RSI is one tool in the toolbox. And both you gentlemen are exactly right. So again, if we don't have an airway and we don't have breathing, pretty soon we're not going to have a person. So again, as you're going through, and the key thing to remember here is you don't have to go through all three drugs. Sometimes, again, particularly with some patients, you will see this flash pulmonary edema that will begin to develop. And the bronchial constriction will be so severe that these patients are just circling the drain really, really quickly. In that situation, yes, RSI would be most definitely a tool that you would want to take in consideration. Keep in mind, depending upon what type of RSI drugs you're using, it could potentially make the bronchoconstriction worse. That would lead into what for you to keep in mind. Say it again. Now remember, if it's bronchoconstriction, a crike is not going to make any difference whatsoever. So now, it's not necessarily going to cause laryngeal edema or laryngeal spasm, but it can potentially worsen bronchoconstriction. What do you need to remember in that situation? If you're bagging a patient and you've got severe bronchoconstriction, what's it going to feel like? It's going to be tough. Your compliance is going to be really, really hard. Okay. And again, the other thing to keep in mind is, and only you're going to be able to answer that is this going to be best to try to transport my patient to get them to the hospital quickly enough to where we've got somebody that has more experience than I do in dealing with RSI in a failing airway, or do I not have time? Now I have to do that. Again, remember, rapid transport is a treatment in the toolbox, and sometimes it's appropriate. Other times it's not appropriate, and you have to go in and do that. Good, very good, both of you. With these patients, they will often be very unsteady on their feet, and they can potentially now begin to hallucinate. In late stages of this leads into unresponsiveness, leading into a potential coma. And as their respiratory status continues to go downward, now they begin to go into cardiac arrest. Questions on hydrocarbon? Key takeaway here for hydrocarbons is airway, airway, airway. Understand and know that route that you would go with pharmacological interventions, as well as the importance of the CPAP. That's going to be, because you're going to have to have that. Methanol. Methanol is wood alcohol. Methanol is poisonous. It will kill you from the first drink if you're not careful. Methanol is found in things such as windshield washer fluid, gas line antifreeze. They put it in there so that this material does not freeze in really, really cold weather areas. You can find it in little cans. I don't even know if they still make it. Little cans of what's called sterno that is used for keeping meals kind of warm and stuff along with this line. You can find it in embalming fluid. It is a very, very strong type of preservative. Wood alcohol or methanol is colorless, and it has an entirely different odor than does normal alcoholic beverages that people may drink. Now, again, poisonings from methanol can either be accidental or they can be intentional. I think I shared with you the guy in Georgia that would get his alcohol by straining white shoe polish through a loaf of white bread. And what he wound up with was methanol. And again, when he would drink, he would get really, really sick after drinking that. Now, basically what you're looking at in here is with kids, quite frequently, you can see that as an accidental ingestion as well. The same thing, and the thing to keep in mind with kids is generally they're not going to get a lot into the GI tract just simply because they're looking for things that taste sweet, that taste good. Trust me, it's not going to taste good for these particular patients. Now, the big thing to keep in mind is that as the body takes methanol in, it gets converted in the liver into two different types of products. First product that it gets converted into is formaldehyde. Formaldehyde is used in embalming fluid, okay? And so then it gets converted after that into formic acid. Now, what I want you to do is to think for just a minute, as this process is occurring, from a pH level, what would you expect to see in these particular patients? they're going to become acidotic. Now, anytime that we're talking about acidosis or alkalosis, the next question you should always ask is going to be, is this a respiratory acidosis or is this a metabolic acidosis?
Metabolic.
Very good. Now, let me ask you, can you effectively treat a metabolic acidosis by respiratory control? Say it again, Trap.
Body ultimately is converted to the CO2 first before it can be breathed off.
But it's not converting it to CO2, it's converting it into formic acid.
Your body creates a lot of bicarb naturally to then create this.
Say it again.
We push our own bike.
We can push our own bicarb here. This is going to be one of the few times of when you're going to be legitimately able to use bicarb. So yes, you're exactly right. So finish what you were saying about that chemical process of the body creating bicarb. And then Eli, I'm going to come over to what you just said.
So your body has to maintain a certain balance at all times, between red blood cells and all the components within the blood. Bicarb, albumin, all of those different components make up the pH balance and they help balance it. So first, your body has to raise the bicarb to create, to balance it out with the free hydrogen ions, and then you can breathe it out.
So the problem with methanol is that the bicarb comes about as to a large degree because of the role of the kidneys. Formic acid is deadly to both the renal and the hepatic system. Therein, we come back to your idea. What we want to do is that we want to artificially change the body's pH to, this is one of the few times of where we can help to neutralize a chemical safely by being a help to the body by giving some additional bicarb. What would you estimate would be your dosing regimen for bicarb in this particular patient? We're going to want to give 1 milli equivalent per kilogram for bicarb. And that's generally going to be the way that's always going to be, unless we're dealing with pediatrics. And I will not ask you any pediatric questions about bicarb because I want you to go back to your reference to look those up. As formic acid begins to develop in the body, it leads to an altered mental status. Our patient can very quickly move from being combative to being lethargic to being unresponsive really, really quickly. The other thing to remember is that methanol does not react well with the stomach contents. So as you lose your ability to be alert and awake, now we run into a huge issue of a respiratory aspiration type of problem. Go and get your suction equipment ready so that, because you're probably going to need this as far as you're going through. It does not take a huge amount of methanol to start causing huge problems. Again, sometimes we find patients that will have ingested, in particular, children will find that will have ingested antifreeze because it has a sweet type of taste to it. It doesn't have that nasty taste that it kind of covers up some of the methanol type of taste that's going on. Methanol can lead to permanent blindness of your patient as well. And so again, that's the kind of thing to keep in mind as far as when you're looking at this. The time of the symptoms that we would see, depending upon the patient's digestive system, but depending upon the function of the liver, is that we can begin to see signs and symptoms of anywhere from about 40 minutes to 24 hours after they ingest it. Usually it's going to be down on the lower end of that. When we're looking at ethylene glycol, again, it is a type of a hydrocarbon that is used in windshield deicers, antifreeze, things along that line. We see ingestion of this, like I said, in small children because it has lots of bright colors to it. The other thing to do is that when you're, well, if you've got pets, and in particular dogs, make sure that you're very, very careful when you're putting this into your car, that if you spill any on the ground that's around you, try to get that cleaned up, because this is almost 100% fatal to dogs, and dogs seem to gravitate more towards it than do cats, because it's very, 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 very sweet for this. With this, basically what we're looking at here is that we see a depression, a reduction in the central nervous system for these particular patients, leading into serious lethargy and potentially having hallucinations. So these patients can often become very, very combative. Best case scenario that you can hope for with these patients is quite often that you'll be able to preserve liver and renal function. Now let's think about this for a second. Would there be a benefit to giving our patient a fluid bolus in this situation to attempt to dilute the solution that's flowing through the blood? And if so, tell me why. If not, tell me why. Pleasure.
I don't think it hurt.
No, it's not going to hurt at all. It's not going to hurt. And again, keep in mind that when we increase the fluid in the body, what does that do to the kidneys? It causes the kidneys to begin to filter. So if we can dilute it prior to it getting in full concentration into the kidneys, we may just be able to help preserve some renal function for these patients. Most of these patients will eventually have to go on dialysis because it is very toxic to the renal system. As far as the liver, there's not much that we're going to be able to do as far as protecting that. The dilution of that is really not going to come into play as far as helping to reduce the damage to the liver. Yes. Good question. What I would tell you to do is, keep in mind, most of the time these patients are not going to be in a hypovolemic state, and it does not cause vasodilation. But what I would tell you to do would be to start out with about a bolus of about 500 milliliters as quickly as you can get into it. Again, listen to your breath sounds and make sure that you're not putting your patient into pulmonary edema. Good question. When we're looking at these patients, again, the thing that we're going to look at is potentially going to be giving patients with ethylene glycol thiamine. Okay. Primarily what it does is that thiamine will help to detoxify the ethylene glycol. Okay. Now, the other thing is in these patients, if it's severe enough and they're having seizures, then we would fall back on our benzos for our patients to manage those seizures. Again, everything you got to take in consideration here with a benzo is you got to watch the respiratory status of your patients. Botulism is not something that we see a whole lot anymore, but it is indeed life-threatening for a patient. And basically, we get botulism from improperly canned foods. The most frequent type of onset we would see with this would be people that still do, and a lot of people do home canning. They improperly get a seal in there, and the bacteria begins to develop in there that can lead into poisoning for our particular patients. Generally, we come into contact with the bacteria on a regular basis. It's found in soil, and for patients that have good, strong immune system, it's generally not going to be a big issue. The other thing to keep in mind, this is one of the reasons why, again, as you're going through, and Travis, you're starting adding children into your family, letting your kids play in the dirt is actually a good thing for their immune system. Too many times people, well-meaning parents want to isolate their kids and not let them do anything except keep them 100% spick and span and clean. And that's actually not good for the immune system. And in this situation, this is a good example of just playing in the dirt. External exposure to this as well as other things is actually very, very good for our for the immune system. Generally, what we see is from a commercial perspective, we don't see this a huge amount within the states. But again, with these patients, we see them beginning to talk and complain about symptoms of food poisoning. They'll have a headache, they'll have some nausea and vomiting. It'll progress on into now leading into an altered mental status. And the interesting thing with botulism is that it can result in either paraplegia or quadriplegia because it begins to affect the nervous system. What kills these patients is usually respiratory impairment. Because again, as part of that quadriplegia or the paraplegia, the nerves that control the diaphragm become paralyzed. And without that, we're not able to breathe. Treatment is supportive. Basically, if you've got a patient and you come across, and most of the time, if you're dealing with somebody that is suffering from botulism, it'll be one of two things. One, it will be somebody who has eaten their grandmother's, canned tomatoes that she canned 12 years ago and they never really did seal perfectly. Or we're going to be dealing with somebody that has immigrated here from a third world country that had food that was not necessarily the most safest as far as canning. If you're dealing with botulism, again, focus in on supported treatment, and the supported treatment that we're primarily going to be looking at here is management of the airway. And these patients, they're most definitely going to need some type of advanced airway maneuver that you're going to deal with, whether that's a supraglottic or an endotracheal tube. But generally, you're not going to have any problems as far as getting them ventilated. Last thing we're going to talk about today is cyanide. Okay, cyanide is a potential for any firefighter. Okay, if you're a firefighter and you're doing an interior attack, you should always have your breathing apparatus on, including when you're doing overhaul, because the chemicals that are released from the modern substances that we have, cyanide is definitely one of those that can be released in there. Cyanide we see a lot. I used to work out in Colorado, and we had quite a few gold mines out in Colorado, and cyanide was a chemical that was used to help to refine the gold once they got it out of the gold ore. Again, in the past, cyanide has been used as a type of a gas in capital punishment. Generally, they don't use that anymore. They've transitioned over either to lethal injection or nitrogen now. But the big thing that we're going to see is for you, those of you that are working in the fire service, you're at a huge risk, as is any of the people that you would pull out from a burning building. The bottom line here is what we see is that we have a big issue with cyanide linking up, similar to what we would see with carbon monoxide within the hemoglobin. And basically what it does is it keeps the oxygen from attaching to the hemoglobin. So you can get your patient out and you can get a lot of oxygen in on your patient, but unless we're able to move that cyanide off of the hemoglobin, we're not going to be able to get our patient into an oxidative state. Generally, what we're looking at here is that if you're dealing with a large concentrated dose, cyanide will often be fatal within just a very few minutes, and it causes asphyxiation. Probably probably not as much now as what it used to be, but in the 60s and 70s and the 50s, even during the Cold War, sometimes spies would carry cyanide tablets with them rather than to give themselves up or to give information over. And in particular, we saw this particularly during World War II when spies of whichever military they were working for, again, would choose that route. It was really, really quick. And once the process started, there wasn't anything that could be done to stop that, primarily from the respiratory arrest. Once you get your patient out, again, primarily from a burning environment, give them high flow oxygen under pressure. Similar situation is what we're dealing with when we're dealing with carbon monoxide, of trying to push that off of the patient. Now, what happens in here is that if it is a cyanide gas and we get a large amount of that cyanide gas into the stomach, it mixes with the hydrogen that's in the stomach, and it can cause explosive vomiting for a patient, which now, guess what? Puts you at risk as well. Generally, what we're looking at here is there are some types of overdose or exposure kits that you would be given for these particular patients, and they're called cyano kit. And in particular, one of the big things that you will see within this is vitamin B12. And so that's the takeaway I want you to remember on that. So vitamin B12 is really good as far as moving the cyanide molecules off of the hemoglobin and leading into oxygenation for our particular patients. And that, ladies and gentlemen, is where I am going to stop. Are there